Welcome to the class. So today's session is about management of vulval conditions 2014 UK National Guideline. We begin with our quote, Master MRCOG with concept oriented clarity. Today's topic is going to be very important from examination point of view because there will be at least two SBAs and two EMQs from this particular topic. There are various dermatoses. You have lichen planus, lichen sclerosis, and lichen simplex, etc. And these are the questions for EMQs. And whatever discussion you will today we will have, please take down the notes. Please note down the important buzzwords from each of these dermatoses because you need to identify this particular condition. Especially there are buzzwords from signs and symptoms, associated autoimmune disorders, then typical histopathology and treatment, etc. Okay, and a few figures are also there, like the chance of development of the malignancy. So we begin with today's topic of management of vulval conditions. So what we are going to see today, the main categories of non-infective vulval diseases such as dermatosis, pain syndromes, and pre-malignant conditions. So we will cover today vulval lichen sclerosis, vulval lichen planus, vulval eczema, vulval lichen simplex, psoriasis, VIN, that is vulvalintraepithelialneoplasia, and vulval pain syndromes. What is the general advice which is given to patients for vulval condition? This is important from part 3 examination point of view because when we are talking to the role player, you don't have to give only specific treatment, but we have to give general advice, the general vulval care. Okay, so this is avoid the contact with the soap, shampoo, bubble bath. Simple emollients can be used as a soap substitute and general moisturizer. Avoid tight fitting undergarments which may irritate the area. Avoid use of spermicidally lubricated condoms. The patient GP should be informed. The STI screening should be considered in all patients and vulvovaginal candidiasis is excluded if the patient presents with vulval itch. So if you have a vulval itch, always exclude the vulvovaginal candidiasis and STI screening. Okay, all patients should be assessed for sexual dysfunction. This is very important because these vulval conditions may be associated with the sexual dysfunction. The patient's quality of life must be getting affected, and that needs to be pointed out, especially when you are performing part 3 MRCO gestation. Okay, and what about the sexual partners? Partner tracing is not required unless the screening detects the STI. So once you do the screening and it is positive for STI, then you go for tracing of the partners. Otherwise, routinely not required. So the first condition we begin as a vulval lichen sclerosis. So what is vulval lichen sclerosis etiology? It's a chronic inflammatory dermatosis of unknown cause. It has got autoimmune association. There is a strong evidence which suggests that autoimmune involvement. There is a higher incidence of other autoimmune disorders in females with lichen sclerosis. There is a presence of autoantibodies which are against extracellular matrix protein 1. So ECM1 antibodies against this ECM protein 1 antibodies are present in lichen sclerosis. What are the symptoms and signs? Symptoms are itching, soreness, dyspareunia. If there is an introital narrowing, there may be fusion of the labia minora, etc., and there may be dyspareunia. So there may be urinary symptoms and other symptoms such as constipation if there is a perianal involvement. It can be asymptomatic, but that is rare. So most of the patients will be symptomatic this lichen sclerosis. What are the signs? You will have a pale white atrophic areas affecting the vulva. There is a purpura which is common, fissuring, erosions, but blistering is rare. Hyperkeratosis can occur, and please remember this buzzword, figure of 8 distribution. So changes may be localized or show a figure of 8 distribution involving the perianal area. So if you in the clinical features, if they have given the distribution in a manner of figure of 8, your diagnosis will be vulval lichen sclerosis. It is a pale white atrophic area affecting the vulva in a distribution of figure of 8 manner. Okay, there will be a loss of architecture, loss of labia minora, midline fusion, etc. So if you see these features in the scenario, please select vulval lichen sclerosis as an option. Then what are the complications? The complications, development of squamous cell carcinoma, the incidence is less than 5%, actual risk is less than 5%. Development of clitoral pseudocyst can happen, sexual dysfunction, dysesthesia. Diagnosis is mainly clinical, usually diagnosed by characteristic appearance of lesions, And histopathology. Please remember the histopathology of these particular lesion. Most of the students get confused at the level of the histology. Okay, so we after finishing these dermatosis, we'll have the comparative presentation of all these dermatosis, so you can remember easily. Okay, so histology: thinning of the epidermis, subepidermal hyalinization, and deeper inflammatory infiltrate. So if you see the epidermis, which is thin, there is a subepidermal hyalinization and deep inflammatory infiltrate. Diagnosis is a lichen sclerosis. Early disease, histological changes may be subtle and difficult to identify. Biopsy routinely not required, but if required when the diagnosis is not certain and the lesion is atypical, or if you suspect VIN or squamous cell carcinoma, which is also a complication of lichen sclerosis. In these cases, you have to do biopsy. Okay, then autoimmune screening, because this condition is associated with other autoimmune disorders, so you will do the screening for thyroid dysfunction, T4, TSH, and if clinically indicated, other asymptomatic association is also known. Skin swab: if you suspect infection, go for the skin swab, and if the allergy is suspected, patch testing is required. Okay, then what is the treatment? Now treatment is general treatment, what we have discussed already, that is required. Then we need to educate the patients and provide written information, explain small risk of neoplastic change to the range of 5%, prompt review, and especially if there are new lumps, hardening, or major symptom change, then we need to do the biopsy. So any change in the symptom or not responding to the steroids, which is a indicated treatment, if there is a lump or there is a hardening, these patients, the next step will be perform the biopsy. Okay, so what is the recommended regime? Here, ultra potent topical steroid, clobetasol propionate 0.05% is the first line treatment. Remember, this is a single based answer question, most frequently asked the treatment of choice for this particular condition, or they may give you diagrammatic picture and they will ask you the treatment, and they give you they confuse you. They'll give you the clobetasol propionate. This propionate they may change to other salt also. You will have clobetasol, then here salt will be changed, and here the percentage will also be changed. It will be 0.5%, 0.05%, 5%. Okay, then there may be hydrocortisone, etc. So the strength is clobetasol propionate 0.05%, and it is an ointment. There will be another option of same with a cream, and another option will be of with ointment. So please select clobetasol propionate ointment 0.05%, and the typical use is how it is to be used: daily to be applied for 1 month, then alternate for another 1 month, and then twice BD for 1 month. The patient will be reviewed at 3 months, and after that, SOS the treatment will be given. Okay, so daily, then alternate day, and then twice a week. Okay, so that is the 3 month, and for 3 months, very small amount, 30-gram tube is required over a period of 3 months. Okay, formulation is a ointment based that is preferred. Okay, over the cream. Then what are the alternative regimen? If secondary infection is suspected, the short course of ultrapotent steroid plus antibacterial antifungal you can combine. So clobetasol with neomycin and nystatin can be used. Fusibat cream can be used, and this is used for short term to clear the infection. Okay, so if you have infection, you have to add other antibiotic also. The other treatments are research and unlicensed treatments, so they are not first line treatment. First line treatment is a ultra potent topical steroid. Here you have calcineurins, which are used topically, and oral retinoids. Okay, here the thing is to be remember, these are actually research and unlicensed treatment and not the first line treatment. Okay, so tacrolimus and pimecrolimus, they can be used. The response is around complete remission is seen around 40% of cases. Okay, but side effect is local irritation which can happen, but it improves over a period of time, but malignancy risk is there. Okay, the other treatment is oral retinoids. Okay, it is useful in severe refractory cases, should be prescribed by the dermatologist. It is highly teratogenic, so avoid pregnancy for 2 years post treatment. Okay, so they ask you about the patient is on retinoids for how many days the pregnancy should be avoided. So if the patient is on oral retinoids, the pregnancy is to be avoided for 2 years. There is a difference between the oral treatment and the topical treatment. Okay, the difference in avoiding the pregnancy, when it is given orally, it is for 2 years. Okay, the UV A1 phototherapy is also there, but the main treatment of choice is the topical ultra potent steroids, clobetasol, propionate, 0.05% ointment form, 30 gram to be used over a period of 3 months, and daily application for 1 month, then 2 times, 3 times, or alternate day for 1 month, and then 2 times a week. Okay, this you specifically remember. Then figure of eight distribution, then typical biopsy features. Okay, so these are the buzzwords here. Then when you are using the topic oral retinoids, the pregnancy and breastfeeding, topical steroids are safe, but calcineurin inhibitors are contraindicated, and retinoids are absolutely contraindicated during and up to 2 years before pregnancy. Use with caution in women of childbearing age. Onward referral should be done to the referral vulval clinic if disease is unresponsive to treatment. VIN or squamous cell carcinoma develops on lichen sclerosis background. Okay, surgery only for VIN or squamous cell carcinoma, or if there is a fusion. Okay, there is a fusion of the labia minora, and if it is causing discomfort, that is the only indication for the surgery. Recurrence common near the scar. Okay, follow up. So initial review is at the end of 3 months to assess the response. If the disease is stable, then disease to be assessed annually. Okay, auditable outcome measures are biopsy performed if there is no response to initial steroid therapy or raised lesions. Target is 100% of such patients, and patient information should be provided, and the target is 100%. Okay, so indication of biopsy when there is no response to the topical treatment, or when you are suspecting VIN or squamous cell carcinoma, then you go for biopsy. Okay, that finishes the vulval lichen sclerosis. Thank you.